Hi, everybody. Hopefully this week I'm going to discuss a bit on knees and emergency radiology, specific to the knee. It's quite an expansive topic, so I've tried to break it up into smaller parts and receiving some feedback from you guys. And thanks for those who have responded and who have given feedback. On the slides, you'll see there's a lot more content on the slides so that when people are reviewing the videos and the presentations, apparently some people don't enjoy just listening. They like to also read what's going on. So yeah, hopefully this will help them as well. So yeah, let's get into it. So we're going to start discussing the knee, which is probably one of the most important joints in the body. Not that any are not important, but it's also one of those where we see a lot of repeated injuries. And it's one of those where, if not treated properly, can lead to long-term disability and pain for patients as well. So one of the common things that we see in the emergency department is knee dislocation. Now, posterior knee dislocations are the most common, although you do get anterior and lateral dislocations, but the posterior are the most common. And the thing is, having seen a lot of these, a lot of the time, and even here it says 50% of the knee dislocations, they spontaneously reduce. So what happens is the knee dislocates, the patient screams out in pain wherever they are, and then the knee goes back into place. Now, you may have a patellar dislocation as well, which also occurs. Sometimes it doesn't occur, it's just the knee dislocation. And sometimes you have a combination of both. So generally on the radiology, what you normally see is this type of a picture with your femur being anterior displaced and then your tibia being quite posteriorly displaced. It's not a difficult diagnosis on radiology. What comes, or where the problem comes about for most people, is management of this condition. Now, the main thing to note here is that let me try just get a bit of drawing going on here. So what happens is that you have the radiofemoral artery that's normally coming here. Now, we're just going to imagine this is a normal knee at first, and this trifurcates into three. All right, so the posterior tibial, anterior tibial, and the what is the third one? Is the sural nerve or sural artery? Okay, I stand to be corrected on that. But anyway, so you have the three that normally come out from here, and then they continue on their way. Now, as you can imagine, when this dislocates, there's a possibility for all three of these to be compressed. So you can end up with a situation where there's absolutely no flow below this point. And the neurovascular damage that takes place, because remember the femoral nerve is also traveling around there, and that also splits in posterior, anterior, sural nerve, your peroneals, things like that. So you've got this entire area that is now neurovascularly compromised. And this is probably the biggest problem that comes about with posterior knee dislocations. So what a lot of people do is that they assess the patient, they then try and relocate the knee, and then they forget about it. And that's probably one of the reasons why a lot of people find themselves faced with litigation and medical legal issues, because this, and I want, even if you remember nothing else from this lecture, remember that the neurovascular compromise in a posterior knee dislocation is one of the most common injuries associated with the knee. Well, I mean, one of the let's say the worst complications of any knee injury. What will happen is that as it gets cut off, the knee, the entire area of the calf, the shin, the foot, slowly and surely becomes colder, and eventually becomes gangrenous, and it normally needs an above-knee amputation. So the possibility of long-term disability for this patient is extremely high. So you have to be extremely careful with these patients. So what you do with the posterior dislocation, first thing is assess the neurovascular status of the patient. Now, this is even if it's relocated spontaneously. The reason being that it can often get entrapped between the bones here, which can happen with a normal reduction as well. If there is no blood flow, or you cannot palpate blood flow, if you have a Doppler, great. But just the fact that you can't palpate should already tell you that there is a problem. However, if there is some Doppler flow that gives you a bit of leeway and a bit of time, at least the leg is being supplied with blood, but you'll often find the limb is cold, there's decreased sensation, there's decreased capillary refill. And once you have these signs, you need a CT angiogram as quickly as possible. The CT angio will then tell you how bad the obstruction is, and then you need vascular surgical involvement or general surgery to get involved. Now, if there is good blood flow, let's say you've got a patient coming in like this or like this, and there is good blood flow, in the emergency department, depending on where you work, there are some emergency departments where all reductions are done. There are others, for example, in our emergency department, where all reductions are done by orthopedics. No matter who does the reduction, the same tenants stand. So as soon as the reduction is done, you check for immediately if there is a loss of palpable pulses or loss of sensation. Now, if there is, you check regularly at 2-minute intervals. Sometimes there's just a lag. So what happens sometimes is that you do get a bit of a compromise, and then once you've done the reduction, it's relieved, but it takes a bit of time for the blood flow to really start again, which is not common, but it does happen. So you check at 2-minute intervals and you document this. Now, after 3 attempts, so that means after 6 minutes, if you are not seeing any type of blood flow, no palpable pulses, immediate CT angiogram, immediate consultation with the surgical department. The patient needs to go in for emergency theater. Basically, they need to be able to move those arteries out so that there is blood flow again. Now, the particulars of the procedure themselves differ depending on what blockages you find, but the most common is a posterior approach. So they'll go in from behind the knee, try and locate the artery itself, and basically physically remove it. Now, in some cases where there is quite significant damage, there's even bypass surgery that's done. There's quite a few things that are done, so especially for somebody who's interested in vascular surgery, would like to do that in the future, it's a really interesting procedure to see. One of my old interns who was actually doing vascular surgery for a little while told me a good joke. She says vascular surgeons only worry about flow, and there's 3 types of flow that they worry about, which is inflow, outflow, and cash flow. So if you are looking for a lucrative career, I would suggest vascular surgery. So sometimes you may get subtle misalignment, like what's said over here. And, any history of the patient experiencing severe pain and then a click, a movement back, or they saw the knee out of place and then moving back, should immediately alert you to the fact that this could be a dislocation and the fact that there could be a neurovascular compromise. Now, the ligamentous injuries that take place depend on the exact circumstances of the dislocation. It was purely posterior, was it anterior, was it lateral? So normally an MRI would actually tell you how bad it is. You can get patellar tendon injuries, ACLs, PCLs, TCLs, LCLs, everything can be damaged, or you may just have a single injury. So the important thing is not to worry too much about the ligamentous injuries in the emergency department. Is the neurovascular compromise. Now, of course, you need to stabilize the patient, splint the limb, reduce pain, things like that. And if you aren't comfortable doing a reduction, don't do it. Chances are, I've seen some attempts by people, and I've seen that they're using the wrong technique. Now, there are quite a few ways to actually reduce a knee. I'm not going to get into them here. I'd suggest that you go and look at them, because there's quite a few lovely techniques for knee dislocation reduction, and most of them actually take into account the possibility of neurovascular compromise. So they allow you to, treat for that, or to make sure your reduction doesn't do that. But the most common form of reduction is traction on the tibia and fibula, and counter traction. So what happens is you ease the space up here and allow it to go back in. There is always a possibility of neurovascular injury with that. There are some other methods as well, which involve flexion and things like that. So there's quite a bit that goes on. Okay, so anterior cruciate ligament tears. Now, these are also relatively common, very common in young athletes, in our younger population and our older population, but can happen to anybody. That's the truth. So these things are these ACL tears are normally diagnosed on MRI. It's very difficult to diagnose it from an X-ray. The only thing that you get that may sort of point you in that direction are the what you would call it, the presence of a second fracture, which we pointed out here, a deep sulcus sign, which you can see over here, and what you call it, I think I've got them mixed up, an anterior spine avulsion. Anterior spine avulsions as well. I've got it on the next slide, so we'll go through each of them. Now, these are things that kind of let you know that there may be an ACL injury, but the most common way to find out if there is an ACL injury is to do an anterior drawers test. So you place your hands behind the knee and you attempt to move the knee forward, which is the function of the ACL is to prevent the knee from sliding anteriorly. The function of the posterior cruciate is to prevent it moving posteriorly. And when you place your hands at the back and pull forward, the knee the tibia and fibula will actually move forward, and that's a positive anterior drawers test, which then tells you, okay, there's a good possibility that this is an anterior cruciate ligament injury, and that's an unstable knee. So you can't let the patient go with that. Now, you do sometimes also get tibial plateau fractures associated with that, but then you normally treat that much more aggressively. So let's have a look at this. So this is an avulsion fracture, which I had mentioned, all right? And you've got a bit of joint effusion as well. And this is your second fracture, yes. So the second fracture also tells you that there's a possibility of ACL tear. And this is a subchondral fracture, which also gives you indications that there may be an ACL tear. But these are all non-specific. But these are things that you can use. And as you can see, this is now an MRI, which is showing you exactly what's going on. So on X-ray, there's not much that you can see, but these are some things that you can look at. Now, I must be honest, I've never diagnosed an ACL from X-ray. It's always been done on clinical examination, but it's something for you just to keep in mind. So meniscal tears. So there's two types. You get acute tears and chronic tears. All right. The most common thing is knee pain and catching or locking of the knee. So as the patient is either flexing or extending the knee, it will catch or it will lock. And you may get joint line tenderness, possibly an effusion, and you normally treat them with surgery in the case of acute meniscal tears, and chronic tears are normally treated via arthroscopy and things like that, but it just depends on the type of tear, where it is. Now, meniscal tears in themselves are an entire section of orthopedics. You can subspecialize in meniscal tears, to be dead honest, because it's such a common injury and it's such a lucrative injury as well, which is not a nice thing to say, but it is true. There's a lot of damage that takes place to our meniscus. Unfortunately, with our population becoming larger, obesity rates increasing, there's more wear and tear on the joints. There's a lot of meniscal injuries that are taking place. So again, a couple of people have asked me over the last few months, they're looking to specialize and things like that. So, if you're somebody who's looking to get into orthopedics, hands, knees, ankles, these are all things that you can get into. So it's important to assess the joints range of motion. So you may get limitation of extension and things like that. Now, these are also basically diagnosed on MRI. Now, when you are going to test it on when you are going to see it in the emergency department, the most common things that you will see are knee pain, especially in an acute tear. You very rarely will you see a chronic tear in the emergency department. But let's say an acute bucket handle. What you'll get is a patient who is refusing to extend their knee. Your x-rays come back relatively normal, but the amount of effusion that is there is sometimes worrying. So this is the type of patient that if you see, and any patient that you see with a large effusion, inability to flex and extend, any sort of catching and locking of the knee, warrants an orthopedic consult. Now, if you're in an area, let's say, for example, where you don't have immediate access to an orthopod, it should form, and let's say you have a normal x-ray, this should form part of your differential. Now, the way to check it on examination is to do the grind test. So the patient lies down on their stomach. You apply pressure, axial pressure from the heel. So you're pushing down on the heel, and then you slowly rotate the knee the tibia and the fibula against the femur, and you normally find quite a bit of pain and an inability to move the knee completely. So this tells you that there is a possibility that there may be an injury. However, this test is very, very, very non-specific in the acute stages. The reason being, most ligament tears, most tendon tears, most muscular tears, most minor fractures will also give you pain when you do them. So it's very non-specific, and I actually don't recommend people doing it in an emergency setting. It's the type of thing that you do to a patient who's presenting with a possible chronic tear. In the acute, you'll have your patient coming in with these severe pain, effusion, generally normal X-ray, or maybe a bit of, a malalignment. Well, let's say not malalignment, maybe a bit increased space between the femur and the tibial plateau. These are the types of patients that you look at and you say, listen, this patient needs an orthopedic consult. Now, of course, depending on the mechanism of injury, you'd base your differential on that. But meniscal tear should always form part of your differential for a patient like that. Now, these are meniscal tears, so you can see on MRI, they're quite easily diagnosed, and it's not something that you need to worry about in an emergency department setting in terms of management. In terms of management, one of the good parts about working in the emergency department, you stabilize the leg, treat pain, arrange for an urgent follow-up with an orthopod. If there is an orthopod available, of course, and the patient needs to be seen within 24 to 48 hours. They don't necessarily need to be seen in the middle of the night as long as you've stabilized the knee. Okay, now posterior cruciate ligament injuries, So these normally occur after a blow to the knee or falling onto the knee with a plantar flex foot. Okay, so plantar flex foot, a foot that's facing downwards. All right. So this was at one stage very common with those who used to ride horses, because when they would fall off the horse, they would often fall with the plantar flex foot, and they would then land on the ground. So that's something to remember if ever you see a patient. A lot of our patients here in our area also ride horses quite often, and it's something that does happen. But as you can see, they will have knee pain and effusion and a positive posterior drawers test. Now, again, the drawers tests are nice. Even your varus and vagus stress tests and all of these things that you can learn about online. The problem is that in the absolute acute setting, sometimes they are of no use to you because they will present positive regardless of what the pathology is, because there's effusions, there's pain, there's so much that's going on. But if you wish to do a posterior drawers test, it's very easy. You place your hands on the front of the tibia and push backwards. The job of the posterior cruciate ligament is to prevent the knee from sliding backwards, and your knee will slide backwards. And that's what it will tell you that it is positive. Now, how far do you go on anterior and posterior drawers test? Just until you can say that it's positive. If you move that joint too much, you're actually going to make the problem worse. So try and avoid moving the knee too much in the acute stage. I'm not a big fan of moving the knee in the acute stage unless your patient has minimal symptoms, or let's say a grade 1 tear. So there's minimal effusion, minimal pain, but they are having some sort of pain. Then you would attempt to do these because it could show a grade 1 tear, for example, So the patients sometimes do return to sport. Treatment is primarily conservative depending on the type. So this is the one type of fracture that you may find, which is a posterior tibial spine fracture. So there you can see that it's actually lifted off. And of course, if you see a fracture like this, the main thing is the fracture. The ligament injury would be found later by the orthopods. Okay, right. So patella baha. Patella baha, I hope I'm pronouncing it. That's what I saw on Google on how to pronounce it. There's also something I learned about. I never knew that a low-lying patella was called patella baha, but patella baha is a low-lying patella. So it's a lateral radiograph of the knee. So normally what shows you what's going on. So there's normally injury or tendinopathy of the quadriceps tendon or muscle. So basically the superior part of your patella, the tendons attached to that, forming that part of the patella tendon, those generally get damaged, but when you get a low-lying patella or patella baha, it's not necessarily that the injury is to the Patellar tendon itself, it may be a bit higher than that, and you can get congenital patellar baha as well. So this is what it looks like on X-ray. So you get this low-lying patella. As you can see, it's tilted anteriorly, and this is its MRI findings, so you can see that's slightly towards the proximal end of the patellar tendon or the mid-patellar tendon, and on this one as well. So it just depends on where the injury is taking place. So the higher up the injury in the tendon, the more it tends to go forward. The lower the injury, the more it tends to droop downwards. The most common findings are pain, effusion, and a mobile patella as well, which can sometimes be confused with a patellar dislocation. The patella can more easily dislocate in these cases. So these are the things that we need to worry about. So the question comes about, what about management? Management is very easy. Stabilize the knee, analgesia, anti-inflammatories, orthopedic consultation, because most of them require surgical repair. So that is the end of part one. Like I say, I've tried to keep these a bit shorter now, and hopefully we'll get onto the more juicy stuff like tibial plateau fractures and things like that in an upcoming presentation. But for now, I hope you guys enjoyed this, and I hope you learned something as well. Okay, keep well. Bye.